All right, good morning, everybody. Thank you for joining us for probably the last training we're going to be doing for ESO before our go live October 1st of this year. So this is pretty informal training we're going to have. We're going to go over just some new things. Maybe you haven't seen a couple new tabs on the on your ESO dashboard. And then also we're going to go over the new SOG that's going to be coming out. And then we'll have like a Q&A session after that with, any questions you've run into, concerns, problems, whatever. We want to try and answer those as best as we can. And if we don't know the answers, we'll definitely find out the answers for you. And then last but not least, any battalions and acting battalions will stay on, and we'll go over the quality management tab, which will be real short, doesn't take very long pending questions. So we'll dive in here. So first, as you know, you always have your EHR incidents tab that's going to be available to you. Some new ones is the Academy tab shown right here. I'll actually change my. So the Academy tab is shown right here. Right there, it's a little book. So if your password and username are the same for ESO and for Fire Rescue 1 Academy, that's a single sign-on. So all you have to do is click that link and it'll sign you on automatically into Fire Rescue 1. If not, it'll just take you to the login page. So if you want it to be a single sign-on, you can just go to ESO dashboard, click that, it'll take you right to Fire Rescue 1 Academy. And just so you know, we're recording this session, and what I'm going to do is download it, put it on our YouTube channel that Chief Crable gave me access to, and then we're going to add that as a class on Fire Rescue 1 Academy. So anybody who may have missed this class, or if we need a refresher before the end of the year or before October or whenever, you can go on there and get credit, CE credit, but also you can watch the class. So that'll be available to you. And then last but not least, this new tab all the way to the right, AC is, and if it looks familiar, it's our station check. They call it assets and checklists. At some point, allegedly next year, they're going to be integrating fully station check into ESO, because ESO bought station check right after we purchased station check. So that tab is right there. It's not a single sign-on. You still have to sign in the station check the same way you do now, but there's a tab right there. So it's kind of a single location that you can go to get the station check, whether it's on your personal phone, iPad at the station, computer, et cetera, et cetera. So just so you know, that's those couple tabs are there for your availability. Next, we're going to dive in here to the new SOG. It's actually been revised. I shouldn't say it's new, it's been revised. It's SOG 405 incident reporting. So we're just going to go through a couple things that has changed on it. Obviously, anything in yellow is what's changed, and we added ESO to some of the things, but there are some procedures that have changed in regards to, because ESO is a little bit different on some things compared to IMS. So as you know, we obviously, send our fire reports under fire performance letter A to NIFRs. So that's through the ESO fire incidents report activity. All the battalions and acting battalions will on duty shall be responsible for completing an ESO fire incident report if 2 or more lines were put in service, except for grass, trash, vehicle, and other fires where the loss estimate is not significant. Now, you might ask, well, what is considered significant? That'll all be determined, by the battalion, the chief officers, the bureau, and they may say, hey, we need to change it up or something like that. So that'll all be kind of determined based off of that. So obviously, this is a guideline that we're trying to make sure that everything is streamlined across all 3 shifts for the most part. So there's that little change there. Next is a little bit of a new one for us. So obviously a narrative is included in the body of the ESO fire incident report and shall be completed with all available and necessary information. Each fire department unit that responded to the incident shall enter a unit narrative explaining actions taken as well as their other details of an incident based on roles that unit filled while at the scene. So all sectional commands such as interior, roof, etc., should provide a written summary of their actions, including results via the unit reports narrative and the ESO fire incident report. And real quick, what it's talking about is under the incidents, fire incidents tab, you go to whatever call, let's say we're going to this call, for example, you have your basics tab with all the general information. This is the overall basic information about the call in general. And then you have your incident narrative, which is all the way at the bottom here. That is about the whole overarching incident as it is. Then under unit reports, that's what that line item we just talked about is talking about. You have each unit that has its own report. Okay, so let's say this is engine 4, engine 5, for example. Each unit would have to go in and put in their own information, like what actions did you do, your times, obviously. This is your actions taken, so you can put up to 4 in there, who was on that truck, and then if it was a structure fire, you can put, you know, the fire product, what you're exposed to, how you deconned, etc., and then the action specific to that person you can put in there, and then the unit narrative will look like this. So for example, let's say engine 4 and 5 went to a fire alarm. Engine 4 was first in, they do the report, they canceled engine 5. All engine 5 would have to go in here and say canceled en route, or got on scene, stood by the FDC, was canceled while standing by. It doesn't have to be anything immaculate. It just has to be something you have to put in there. So that's a little bit of a change. So unlike what we do now, obviously the first unit on scene completes the whole report. That's not what's going to happen moving forward. Now, just as a reminder, let's say it's a medical assist or for a cardiac arrest or a car accident, for example, a NIFRS report or fire incidents report always has to be done when 2 or more units are dispatched in and out on the call. Okay, so obviously on a car accident, the rescue would do their own NIFRS report or fire incident report, just like it is right now. And then the EMS EHR, the medic unit, would complete their own EHR report as they do now. Now, if it's a cardiac arrest call, for example, and Rescue 1 went with Medic 2 to a cardiac arrest, right now in the SOG, it says that the officer OIC on the medic unit will complete the EHR and also complete the fire incidents. Now, with IMS, that was streamlined and pretty easy because you wouldn't have to go to 2 different places. But now, what we have right now is that the officer OIC, since they already have access to that report, they will complete both. Now, this is pretty simple information, nothing really earth-shattering, but I wanted to get you guys' input because we talked about it on A shift a little bit. We got interrupted for most of it, but there was some discussion about if Rescue 1 responds from Medic 2 on a cardiac arrest, should Rescue 1 just come back and do their own NIFRS report? So what are you guys' thoughts on that? Because it can be changed in the SOG before it comes out.
So I got a question for maybe like a clarification.
Yeah.
So let's say go on an MBA, Rescue 1, Medic 3. They go, they respond, request another med unit or battalion or both or whatever. When that patient information is transferred to the second incoming med unit, then does each unit have to go to the others report to put their unit in, like you spoke of, for like engine 3 and engine 4 going to an alarm drop? So would like the second patient that would be going with Medic 4, would Medic 2 have to put their times on that one as well, or no?
No, all they would have to do, what we set up on the EHR side, the EMS side, was called auto EHR, meaning obviously the majority of our calls are EMS. So Medic 4 goes on a call today, they don't have to go to this fire incident tab whatsoever on a regular EMS call. And
Okay,
it should be the same thing when it comes to, the only difference is if there's a unit that's coming to assist them with the same patient. If they're coming to do a new EHR, they shouldn't have to access that. Or let's say it's a car accident and there's another unit responding, the rescue still should be doing that NIFRS or that fire.
really, anytime that, you know, the other additional responding units would had to add to the narrative or put something in their narrative would be more or less engine calls and those types of incidents, correct?
Correct. Yeah. Yeah. So unlike IMS, everything was kind of put together. You could go to NIFRS and back and forth. It's a little bit different with ESO. So we wanted to make sure that was clarified with everyone, that when 2 or more units are responding, that second unit, let's say it's a rescue, for example, needs to go to the NIFRS tab, or the officer per the SOG right now on the medic unit to input that information. If you believe that station 1 should do that, let's say station 1 is majority of the time the one who's responding to assist medic units on medical calls, do you believe that they should be the ones putting that NIFRS report in? And what's the common practice now? Because I know it seems to be different on shift from what I'm hearing.
Ryan, I like the station 1 captain throwing that in, honestly, because sometimes after we're done with the code and everything, and I want to find out who the 2 guys are that never came in the house occasionally. You know, I end up waking Sean back up after I'm done with the report saying, hey, who was the other 2 guys that never even came in the house?
Sure.
It makes sense to have, you know, if the rescue's going out to assist with a medic crew, it only makes sense that they would do that, you know, quick NIFRS. It really doesn't take that long. So I'm in favor of that. Station 1 kind of recording their own time when they go on the rescue, putting the NIFRS report in.
And also on top of that, you might say, well, I have to wait on that medic unit to get done transporting or stuff like that. And that's not the case. You can still put this NIFRS information because your times for your unit are completed. And then those runs based off your CAD import, okay? Based off your CAD import right here for this NIFRS run, we'll merge those reports kind of together, okay?
Correct me if I'm wrong, it probably would be able to, you'd be able to extract a little bit more information a little bit easier for reports and end of year reporting, just based on the unit itself without tying it to something else, correct?
Correct. Yep. The more information we put into ESO, even if it's not required based off validations, whether it's on EHR or fire incidents tab, the more information we're going to get out at the end of whenever we, look at analytics and data. So that's just an overarching thought. The more we put in, the more we're going to get out of this. And right now we're kind of sitting at the foundation, and then, next year we might add a few things to say, hey, we want to start tracking this, or we need to start tracking that. So just so you know, we obviously want to get used to the system and the flow, develop your own flow, but sooner or later we might be adding things to say, hey, we'd like to start tracking this, or we want to start tracking that. So.
Sully?
Yeah.
So how's that going to work if the rescue or medic 1 gets back and starts the fire report and pulls all the times off the CAD? How's that going to work with if the medic's not in service yet, when they go back in service and in quarters, is the CAD going to repopulate? Because once you pull it off the CAD, it's gone.
Well, I believe I talked to Stoller earlier, and he believes that when times are entered into the CAD almost in a roundabout way refreshes.
Okay, it'll repop. So then you could go down it so that when the medic gets back and goes to enter their information on the fire report, they'll be able to pull down the CAD again.
Yeah, Matt, you got to refresh it.
Go ahead, Adam.
So when you do a CAD import, you draw that run from the CAD and it's attached to your run report, right? So same thing when a unit's changed the status, whether it's gone in service or in quarters or multiple units, all you do is hit that CAD import again, and it'll say, do you want to refresh it? It will overwrite the information, and then it should refresh it with all that up-to-date information.
Okay, so it'll repopulate on that screen every time a unit changes status?
No, you have to hit CAD import again and refresh it manually.
No, that's what I mean. Because once,
Yeah.
if everybody's in quarters, once you pull that down, it's gone.
Correct.
So every time a unit changes status on that run, it'll repopulate. When you refresh it,
Correct.
it'll put it back up on the CAD again.
Correct. That's the way it's designed. Yep.
Okay.
So then just a clarification on my side then. So if the rescue comes back from assistance, say medic 4, they generate the report first. Are they putting medic 4 in their NIFRS report also, or they're just doing their own thing and then medic 4 will be doing their thing?
So they would do their own. When you do the CAD import, it's going to bring all the units assigned to that call into your unit report.
Okay.
The rescue would obviously be responsible to go in there, complete the personnel and their narrative, and then they can just leave it as it is. And when the medic's done, they can come back and finish up and tidy up what they need to do.
Okay. I think
Does that make sense?
Yeah. I think we are.
Because of
So they
that-
don't have to, you're not selecting who you're importing. You know, when you
Right.
import, it's bringing everything in, just like it shows here on the screen.
Right.
And you would just select what unit's appropriate for you and complete that information. And then
And that
everybody
would
else
be the
can take-
separate NIFRS report for like the rescue.
it's all the same NIFRS report. It's just the section of it. You know what I mean?
Okay. Yeah. Yep. No, I understand. Okay.
Fire medics to respond with the police school resource officer. 745 Recoil Holland Street Northwest. We 27, Barossa 27. For suicidal juvenile female. Jackson paramedic to respond to 745 Recoil Holland Street Northwest. Apartment B is in Bravo 27. This will be for a juvenile female suicide.
All right.
Hey, Sully?
Yeah.
Okay, just another thing to clarify. Two things. When you pull down the units from the CAD into the fire report, it shouldn't, the rescue is gonna have to put in the personnel on medic 2 in order for them to have access to it, correct?
No, because they'll have access on the EHR side. Because
Fire report.
we set it up on the auto EHR, so medic 2, this information should pre-populate for medic 2, for example, because on the auto EHR feature, it does the EHR and auto makes that in a roundabout way a fire incident like it is right now. So they don't really necessarily have to access that unless the system says, hey, you need to put this or that in there, which it really shouldn't because it's marked as an EMS.
Okay. I
That
had another point to make and I forget what it was now, so I'll let you know when I remember.
Okay. All right, cool. Very good. Good feedback. Appreciate it. All right. Got that. So here's a little bit of a change on this item right here. For working structure fires, an additional handwritten or typed report separate from the NIFRS report shall be written by each member of the first in fire company describing initial conditions, observations, difficulties, actions, or any other relevant information when requested by the JTFD Fire Prevention Bureau or Chief Officer. So like it was before, we would automatically, that first in arriving unit would always go to the Word and type their individual document saying, this is what I saw, this is what I did, this is what the conditions that I saw, all that stuff. We're not, the NIFRS tab or the incidents and units reports narratives are going to be sufficient unless, let's say it's an arson, for example, and they say, hey, I want to know exactly what you saw. You 3 of you on the engine, for example. I want to see exactly what you guys saw, and they'll make sure to communicate that to you through the battalion or themselves to say, hey, make sure you do a separate, because if the fact of the matter is they're working around that. They're trying to make this as efficient as possible to say, hey, let's use ESO, let's use fire incidents tab as much as possible. So just off the thought process of always going and making a Word document, putting your own personal views and all that, you don't necessarily have to do that unless it's requested by the Bureau or a chief officer. Okay,
Hey, Ryan.
Yeah.
Since you're in a position where you're working on this SOG a little bit here, Tony had a good point. Should we strike first in and make it any fire company? Because as it's written, you know, the bureau or fire or chief officer can only ask the first in and it's required. Sometimes they might want that second in or third, you know.
I think that would just come down to if they wanted it, then the
It's
request.
at
might be
request.
made.
Since it's at their request, I think strike first in and make it any fire company. And because they'll request it from whoever they wish then.
Right, but I think what this one does, and I understand the point you're trying to make, but this leaves no question that those first three guys are doing it. And let's say 3, 4 o'clock in the morning, you know, we get done with shift, we head home and they forgot to do it. Well, the battalion or the chief grade officer or FPB didn't request it. You see what I'm saying as far as the first one? I understand your point. I understand this sitting on this side of it.
Chief, what this one is saying is that now I don't have to do it unless they ask us.
And they're removing.
They removed the requirement and they made it at their request.
For who? The first in company?
correct.
Yeah,
You know how Chief, we would go to a structure fire, engine 2 was first in,
Right,
those 3 personnel would write that statement.
right.
That's not required anymore unless it's requested by FPB or the chief officer. Because they're saying the majority of the time, the information that is in that incident narrative under the fire incidents tab and also the unit reports narrative, that usually suffices enough information to have for the overarching fire. Now, if it's if they request it because it's an arson or whatever it may be, then each member of that first in company, fire company would be doing that, what we're doing now.
So my problem then lies with the language, because it says shall be written by each member on the first in company, and then below you're saying only if it's requested. So my question then is, if that's very convoluted. It either is or it isn't. And as it stands now, we do that as a standard. The first in company always writes that. And then if there's anything else that would be required or requested from the officers, then they would go to those units and ask. But yeah, I mean, I see that now, and that when I see the word shall and then when requested, you'll get an argument on both sides. Well, I didn't have to, then I did have to, and it wasn't requested. But obviously, we can try things out and see how they work, and we can always revise them just like we do this. But that's a good point to bring up.
No, and that perfectly makes sense. And I'm making notes so we can, I can take these back to FPV and the admin and kind of say, what would you like to do with this type of stuff? And like I said, the idea behind this is to utilize ESO system as much as possible. So documentation, it's not redundant in a roundabout sense within
Right.
reason.
No, good discussions, man. Can get some things worked out and get some clarity. So good.
Thank you very much. Next, obviously, vehicle fires hasn't changed. Equipment fires, we just added on a national level because obviously all the information we gather is pushed through, to NIFRs, and they use that stuff for recalls and such. And then all calls assigned an incident number shall have either an EHR, a fire incident report completed in ESO software. So nothing has changed there. It's just, and then other reports or statements may be required for incidents as directed by a chief officer. So that's the fire reports. If you feel that there's something that obviously other than what we've talked about already that needs to be changed or added or whatever, feel free to send that my way, and we'll definitely discuss putting that stuff in there. Because obviously, as you can see, this is a draft, so we want to go over some of that. Any questions over the fire reports section?
It's good.
All right. Next is EMS reports, or EHRs, electronic health record. So An ESO EHR report shall be completed each time a medic unit makes patient contact, which includes a patient transport to an appropriate facility or a patient refusal of patient assessment and treatment. And then the second one, which kind of adds to that a little bit on that first line item, an EMS report shall be completed anytime a person is assessed or treated by a member of the Jackson Township Fire Department. This includes walk-in patients who are assessed or treated but not transported. If a citizen comes to a fire station for a routine blood pressure check and they do not complain of any symptoms, there is no need for a call number or an EHR. So there's that. And then on top of that, any call for patient assistance, such as assisting the patient back to bed / chair or standing position, and there is no physical complaint or subsequent patient assessment is necessary, a fire incident report shall be completed in the ESO software program. So unlike, you go into the NIFRS tab in IMS, you have to go to the fire incidents tab, and I'll just show you real quick. You go to the fire incidents tab on this call, for example, and you go down to person. Obviously, you put in all the other information that as you usually do. Go to the person / owner, and then all you do is click here, and then you'll add the information like you would do usually on like a no duty on a car accident or so this is where that information will be input for lift assist, for example. And then obviously you'll add all the other information as necessary. And then this is outlining the ESO fire incident report for all patients seen at an incident, including no duty to treat subjects. If a patient refuses treatment, the refusal of treatment report shall be done in the EHR section of ESO, and the patient's signature along with a witness shall be done in the EHR on the appropriate signature section. And just a reminder, the witness signature should be, and I'm pretty sure we're pretty good with this, but it should be someone other than ourselves. I did that for the longest time, and I thought to myself, that's a bad idea. So it should be a family member or friend if that's applicable. So just as a reminder, if you go to the EHR tab, and I'll just jump into this run right here. And just as a reminder for signatures, top 3 signatures, section 1, 2, 3, patient, and then parent of a minor goes here, authorized representative signature goes here, EMS personnel and facility signatures go here. Okay, nothing really changed with that other than kind of the layout, how it necessarily looks, but it's exactly the same information as we're putting in now. Provider signatures is us. Okay, we can put in, you can put up in upwards of 3 or 4 in here. So you can put as many of our signatures as you want. I believe it, if I remember correctly, we talked about this yesterday, it requires 1. Is that right, Adam?
Yeah, so right now it just requires a provider. So maybe we can get your guys' input if you think it should just be a provider or the lead or both. If you just do provider and say you have the OIC as the lead caregiver, it's going to require the attendant to sign it and not the captain or OIC, and vice versa. So what are your guys' thoughts? We could have both, or we could just do lead. My thoughts is lead can kind of be confusing. Is it lead care provider or is it lead on the call like the officer? So I guess just so we're consistent across the board.
Sully, I think that comes down to what you and I talked about yesterday, is who should be assigned to each one of those roles.
Yeah.
Who's the lead caregiver? Is the lead caregiver the officer or OIC, or is the lead caregiver the attendant?
Yeah, that's a good point.
And just so everybody's on the same page here, when it comes to talking about the roles, is under personnel and roles here. So who is who? So my personal view is the lead is the officer OIC. Now, other caregiver, I see as the actual caregiver. I think it should just say caregiver instead of other caregiver, but that's obviously not something we can change on our end.
Mm-hmm.
So and we just kind of want to get the majority so we can make sure that everybody's on the same page. what is everybody's thought process on what is a lead and what is a caregiver?
Two, because the SOG states the officer is the final, say, I guess, on the report, checking for accuracy and everything too. So that's why I kind of lead towards the lead as the officer.
That's what I think too. I think I think it'd be more standard across all the reports. I mean, 7,000 reports a year, just make the officer, oh, I see the lead, and the attendant, the caregiver.
And two, if we switch around to where the lead provider signature is mandatory, you could still have other people sign that record. If somebody, if the attendant writes the narrative, they can still sign under other provider, even if it's not required. So that doesn't go away. This is just what's required for validation.
And just to be clear, there's, it requires one provider signature, but if you do medications, let's say you have a controlled substance, you still come down here and you're still documenting the witness, the medication, the amount, who witnesses the waste, and then you can add another. So you can add 2 witnesses, or 3, excuse me, to that. So you're still adding that information, and you can add more, up to 4 signatures under provider signatures. Facility signatures, I don't really see us using this very much except for airway confirmation. And I would actually push people to utilize this, because let's say you insert an eye gel or you intubate a patient, for example, and you bring them to the hospital. I would want to get a signature in this section to say, they looked at my airway, they're saying it was good. The nurse said it was good. The doctor said it was good. The respiratory therapist said it's good, and I have their information right here. So later on, not that it necessarily happens a lot, later on, they don't say, well, that airway was not secured, FYI. But you have a signature confirming that. So under facility signatures, don't get confused that is where the nurse is going to sign it, the patient's not. That is under section 3 up here, facility signatures. Okay, this is predominantly pretty much, for airway confirmation in my thought process.
You think we're getting pushback from the hospitals and staff on that stuff?
For airway stuff, Chief?
Yeah.
I haven't heard of anything.
Okay.
It's just more of a CYA
Right.
type of thing. As we start using eye gels more for cardiac arrest or other type of calls, it's just more of a cover that, let's say that patient has an anoxic brain injury after, we put an eye gel in or intubate them or something like that. And then they say, well, EMS, whatever. So I would want to make sure that's not, we cover our butts pretty much.
Right. Okay.
And that's something I can bring up on our end at the hospital. Now that a lot of folks are rolling out ESO, I say, hey, this is an option within the reports. Do you guys have any objections to signing this, verifying their airways? So that way, the doctors are all aware of it. We can disseminate that to the respiratory therapists. I don't think it'll be an issue at all.
Apartment 7 for a 73-year-old female with stomach pain.
Can you say that again, Adam? Just for the recording.
Yeah, sorry, I probably should have waited till they were done talking, but I was just saying I could bring that up at our next meeting at the hospital. Just since we do have a lot of agencies switching to ESO and having that capability of maybe that becoming common practice for many agencies. Just so nobody's surprised, when they ask for another signature, because some people get weird. They'll
Right.
put their name on something, they don't know what it is. So, but I'd be glad to bring that up to them, and I don't think there'll be any pushback.
Cool. And then last but not least, when we're talking about refusals, we're in this refusal tab right here under signatures. So per the protocol, we need to have a capacity assessment for our patients that's already set and ready to go for us. If you do have to contact medical control, this is how you would put it. There is a section that you can put not contacted. If it's not required through the protocol, you don't always have to contact them. Patient notifications and a signature for us, and then the patient refusals, comments, the long dissertation of them, why they're refusing treatment, transport, etc. And then last but not least is if the patient refuses to sign, having a witness other than yourself or your crew, if at all possible, they can sign here. So all this kind of stuff is all together. So especially I like the capacity assessment that's already in here because it's, it's right in line with the protocol. Cool. All right. So next, all appropriate information such as the signature, a patient or representative shall be obtained if possible and available. If the patient is unable to sign appropriately or information is not available, that shall be documented in the appropriate section, which includes the signature section and narrative within the EHR. Okay, because there is a section in here that, did they receive this information, witness. So you can kind of almost add some information in here, patient unable to sign there, or did they talk about or know about these HIPAA practices? And then obviously in the narrative, you can add that too. For incidents with multiple patients, an incident number field shall be the same, which is if you're using the CAD import, it's going to be the same. So the run number field shall be used in the EHR to identify each patient. The officers and OICs must communicate to assign an appropriate run number for each patient involved. Now, just as a reminder, there's differences between incident number and run number, and that is found right here. So this is our incident number. So when we import the CAD, which is probably how we're going to be, adding the run number, all that information comes right in here. The run number is for internal tracking only. Okay, so you'll have your CAD import or whatever the call's for. So let's say I'm going to import a CAD right now. So Medic 3 went to let's pick let's go on to Glenmont for this morning. I'm going to import the CAD. It was successful. It changes my incident number up here. So that always stays the same regardless of how many patients you have. What changes is this down here, run number. Okay. So we'll go in and we'll add, okay, I'm patient 1. Hey, Medic 3, who's coming to the car accident, you're going to be patient number 2. It's no different than what we're doing now with IMS. Hey, you're patient 1, we're patient 2, you're patient 3, so on and so forth. Now, on top of that, let's say Medic 2 is on scene of a car accident or Rescue 1, for example, and the patient decides, well, I want to go to the hospital now, or whatever happens. They can actually start a new patient in here, okay? And then they can add run number to import the CAD for whatever, unit's coming, add run number 2 for this patient, for example, if they communicate that with whatever medic unit is transporting, and then they can go to personnel and say, okay, I'm going to add whomever to this report now. Let's say it's an OIC for Medic 2 today. So I'll go down and select that person. Now they have access to this report now. So they, on the way to the call, they can actually get on the EHR and start inputting information that's obviously pertinent to the call, car accident, et cetera, their own personnel, all that stuff. They can add that stuff in there, on the way. So that's the way to have access to the calls, to the EHRs, is when you're as a personnel. If you don't have access, then you're probably not listed as personnel. Does that make sense?
Hey, Ryan, can you do another scenario for me real quick here?
Uh-huh.
You have this patient brought up right now. You've made them run number 1, okay?
Yep.
Now, we'll say Medic 2 is going to transport 2 patients from the scene. Add a patient for me. And how do we change the run number on that second patient? Because it doesn't create a new incident, does it?
No, it's still under the same run number. You're just changing the patient number, which is run number. We cannot change this wording, unfortunately.
Right.
They run number, but it's for internal tracking purposes.
I just wanted to make sure that it was more new information than just
How does it go
patient
between patients now,
information.
those? Do you probably see
It's
one
basically copy and pasting the majority of your incident tab.
down there? We're gonna bring another one.
Yes, so up there so Tony was asking how you switch between the two patients to record stuff now.
Right up here.
That's it.
Yep,
Okay.
but then when you go to the dashboard for EHR, they're gonna be listed as two separate ones. So just
Okay.
make sure, try and put in the patient name as soon as, a last name or whatever for that patient. So if you have to go out of the system, for example, and you go back, you're like, oh, which one? You have a 50-50 chance, of course, but you can pick between the two, or you can go into this. And because they're the same run number, you can still access both units.
And to my knowledge, whatever run number you put in, whether it's 1, 2, 3, or 4, you won't see that that run number reflected on your dashboard. You'll just see that top incident number. So you may have many patients with the exact same incident number. It won't say 4836-2.
Did that answer your question, Captain?
Yes.
Awesome. All right. So next is casualty reports at fire shall use the same incident run number as the fire incident number, obviously, because they all should be kind of together. So the difference with that is obviously we're in the fire incidents tab for that. But then if you're assessing and treating and transporting, for example, or just assessing and treating someone, and let's say it's a patient refusal, that would go under the EHR tab. So you would have to go and let's say somehow you would you can call dispatch and say, hey, medic 2 is assessing a patient, for example, or what you can do is go to just make a new record. And then one way or another, dispatch will have to kind of know that medic 1 is assessing a patient. And then obviously they'll know if you're transporting and such, they'll be documenting your times accordingly. So a little bit of a roundabout way if you're going from fire incidents to EHR, but it still can be done on a new record or a CAD import. So this is what we were talking about, and we're probably gonna, thus far, we'll see what tomorrow has to say, but it seems to be a little bit more popular that, whatever unit is assisting that medic unit on a cardiac arrest or medical call, that they can just complete their own NIFRS report. So this section probably will be modified. Obviously, will be sent out to everyone for review, of course. But right now it says the proper completion of all EMS reports shall be the responsibility of officer OIC on the medic unit. The attendant may fill out the report. However, the officer is responsible for its completion and accuracy. Actually, I think I talked about the wrong one. Down here, where medic unit calls for additional unit or personnel, the officer of the original medic unit must enter the additional units / personnel into ESO on the fire report side. So this is probably going to be modified unless there's, somebody says otherwise. But I think that makes perfect sense for Station 1 or whoever it's going to be to put in their own NIFRS. Now, this one, just as a reminder, due to HIPAA restrictions, only an officer or a medic that render care to a patient may have access to the information on the report. Obviously, if your name is listed on personnel, you have access to that report. Okay. And under the tab for patient information, so we have a patient here, and you go to patient import. So obviously you need two fields, at least 2 fields are required to enter that information. This is only good due to HIPAA restrictions for 150 days. Okay, just as a reminder. So if you take Susie in, today, and you take her in 149 days later, that time frame is going to reset for another 150 days. Okay, now if you don't see that patient, within the 150 days, then it's obviously you'll have to re-input that information. That's nothing we can do. And per HIPAA guidelines, it has to be that way. And that's the max number of days we could do, which was 150 days. And then last but not least is positive ID. So when a medication is administered to a patient, a positive ID shall be completed in the AHR. In order for the report to be locked, all personnel will complete the question bank for use during positive ID. So positive ID, simply top right next to your validations and such. It'll come up with your medication, your name, whoever administered that medication. So the person who administered the medication or their name that is attached to that medication has to be the one who does the positive ID. This is a Ohio Board of Pharmacy requirement. We probably should have been doing it before with IMS, but we're going to be doing it with ESO. So simply, if you haven't set this up, which hopefully you have, you go to this website and if it load. Simply, as you probably have seen already, there's a slew of questions on here that you can pick. You have to select at least 15 of them and put your answers in, and they can't be all the same answers. We have already found out that can be done. As soon as you answer those 15 questions, you're good to go. Now, if you miss a question on the AHR, then it comes up with two of the 15 questions it's going to ask you to answer. Now, let's say you miss one of them, okay? Technically, you can actually go back to positive ID and change your answer, and then go back and then answer the question appropriately with the correct answer. But that's, obviously you want to watch out for that. So that's the positive ID for that. And that is the end of the document for SOG 405. Any questions? And this is the time that we want to open it up to questions, whatever you may have, burning questions you have for us, whether it's fire incidents or EHRs or whatever it may be. So, questions.
Hey, Sully,
Yes, sir.
what are you looking for on the, open up one of those reports, please, and go down to the bottom of the incident tab to the NIFRs there. Yeah. What are you looking for as far as actions taken? ALS assessment, transport, what all do you want on there?
Well, I believe they're, so 33, I believe 33 and 34, is that right, Adam? Or the main set for
Yeah.
transports?
I mean, that's what we used years ago in Firehouse. Are we going back to that now where we're putting just almost automatically on every call, putting those two codes in?
That's correct. Yep.
Yeah, I would.
If it's appropriate. What we're gonna, and that's
32, yeah.
and that's a good segue. Thank you for bringing that up, Matt. I'm putting together a checklist almost, but we're gonna put together we want it to be laminated and put it out at each station. So kind of a reminder, okay, what are these codes again that we used years ago from Firehouse, but also a checklist to say, okay, did I lock the record? Did I fax the record? Stuff like that. But specifically for the codes, because I don't remember all the codes, and we don't want people just using other codes. We want them to be the exact codes that we used before for NIFRs. So we're going to be putting together a document that probably will be laminated and kind of give people some reference on commonly used codes before October 1st.
And obviously you can search in there too. You don't have to know the code necessarily.
Yeah, like I search, let's say it's BLS, there's BLS, ALS. Nothing for that. So, which is nice, obviously, compared to IMS, we can search for a lot of things. Answer your question, Matt?
Yep.
Cool. What other burning questions do you have?
Who has permissions to like if you lock a report and go, oh no, I forgot to enter this, who can unlock a report?
The
And who can-
battalions and acting battalions.
Like if you went to add a patient and meant to do something else, who could delete a blank patient?
The battalions can, anybody with admin rights. So the battalions can currently, and I believe I'll have to double check, but the acting battalions can do that also.
Okay.
And just as a reminder, so you have your report, you're done with it and such, and you gotta send it. So you come over to the I'll call it the dashboard for your AHR, come to the hamburger stack, go to fax. Obviously, I don't have, let's say, I put Stark County Coroner in there, it will send a fax to them. Or if it's Mercy, you put as a destination, it will come up and say, do you want to send this fax to Mercy? And I'll print right behind the charge nurse. Also, same with Altman. We put a whole slew of hospitals in there. So those are ready to go. So just as a reminder, you need to remember to fax these reports. Okay.
Not
Now,
email?
no, it'll be
Strictly
fax.
fax. Okay.
Yep.
Attachments. Can you
Uh-huh.
talk a little bit about those? How many? Is there a limit? What's that look like?
As far as I know, you can have a whole slew because these attachments are also, correct me if I'm wrong, Adam, from your monitor too. So 12 leads,
Yeah.
all kinds of stuff. I'm not sure if
There is a limit, but I think it's a pretty high threshold. You're probably only gonna hit it if you take a bunch of pictures, like a ton of them,
Okay.
but documents don't use it very much because they're in the PDF format. Whatever you want to put in there. You could put, the patient's paperwork in there, whatever else to help documentation later on. Solly, going back, you kind of hit on it a little bit you want to talk about the workaround for the coroner, like you guys had that yesterday. Or do we want to save that for another time?
No, we can talk about it now. So
You
go
want
ahead.
to, or you need to?
Hey, can you talk about real quick what to send when you use a NARC?
Mhm.
So you can get the ball rolling on that
Send to who?
to the hospital so you can get
Oh.
started replacing while you're finishing your report.
So we did have a meeting with the pharmacy last week, and we're still ironing some things out. They're okay with the patient summary report that Solly will click on here in a minute to show you. The only problem we're having right now is it doesn't say who gave the medication, and the pharmacy doesn't like that. It has everything else in there they want, but they would like to know who actually administered that medication. And it just doesn't have it in there right now. I'm going to talk to ESO, see if there's an option or see if they can turn something on. I don't know. That's a long shot. But another option you can do, and what I would do, is you can simply print or fax your report as it is. It doesn't need to be locked. It doesn't need to be synced or anything like that. It could just be as is, and you can fax or print it as it is and hand that into the pharmacy. It'll still say draft on the top and at the bottom, and they're okay with that. Just because it has all that other information in there they want. And then at a later time, you'll finish your report and they'll get that completed report in the back end later.
That's for Mercy.
Yeah, that's just Mercy's status. Off the record, I have done that at Altman without telling them, and they gave me the drugs. So. And you do not have to have your medic card to get medications at Mercy. So they're developing an SOG or a policy actually down there right now. So there's a little more consistency. They probably will still ask you for your drug license, just with changes in the pharmacy board standards, whatever rules they follow. And obviously a driver's license, which we all carry anyway. So does that answer your question, Matt?
Yep.
Okay. Hopefully we can get that fixed with the patient summary report, because I think it looks a little bit nicer. It doesn't say draft on it and everything, but that's kind of where we're at. So.
So for the Stark County Coroner, let's say you need to send a report to them, for example.
Oh, yes.
Obviously you wouldn't be transporting,
Did it allow you to put a destination there without a disposition?
Well, that's what I'm trying out right now.
Okay. So while he's working on this, if we run on a call or we terminate in the field or it's a DOA or whatever, and the coroner needs to get a copy of that report, you can't fax any PCR just to whoever you want. It's whoever's selected in the destination part right there below disposition. So it's just ESO's way of keeping things safe and secure, I guess. So we're trying to figure out a workaround. That way you don't have to, go back to station or on your iPad, save it as a PDF, then email it. Obviously we'd have to get the okay from admin to do that anyway, just with HIPAA. So Sully and I were talking, and this isn't hard and fast, but what if we just change the disposition to that we did transport them to the morgue and put the morgue as a destination, fax it to the morgue, and then just change it back. Again, that's not hard and fast. That's not policy or anything like that. It's just an idea we had to make that work. So basically, we're just changing the disposition.
Yep. So change the disposition to transport it, even though you didn't. Okay. Just for the time being, go to destination type, and you'll go down to morgue or mortuary. Okay. And then the only one in here is Stark County Coroner. And then what you can do is you can go back out to your list for that specific run number. You can fax it. Their fax number is in the system to the Stark County Coroner. Their email is in there also. Oh, should have been in there. I probably picked the wrong one. I can email the record to Stark County Coroner. So that's the workaround for that currently. And then what you'll do once you're done sending it, come back, come up here and say dead patient, and that can finish your report. That's one of the unfortunate things with ESO.
And all this is done prior to you locking the record, obviously.
Yeah.
So we'll keep working on that, and we'll update you maybe with a final, put that in SMG or whatever they want to do that, just so you know what to do.
You talked to about the auto generate for mileage.
Yep.
Mm-hmm.
So let's say we went to Glenmont Drive. Here's the address, the section, all imported from the CAD. We transported the lights and sirens in our ambulance. Let's say we went to Akron General. Okay, the address and all that, it's all predetermined information. Good to go. There's your time, say you CAD imported, delays, and then come down here to mileage. All you got to do is hit this calculate mileage. Bada bang, bada bang. This is done through Google Maps, and it calculates, loads your miles automatically for you. And
Wasn't the
your billing,
question how that was calculating the mileage, if it was from the station or if it was from the scene?
it's from the incident address up here, or the scene address, to the destination, which is here.
All right, so we're safe to use that?
Correct. Yeah, because I think it was NIMSIS only does like roundabout mileage anyways, and I believe our billing only does rounds out billing or mileage also.
Yeah.
So like if you have to do a detour or something like that, yes, it won't calculate it, but they round it out anyways. So unless it's like 10 miles, you're going out of your way, then that would obviously change.
And you can still edit those numbers even after you do a calculate.
Sure. Yeah.
So say you did have just a crazy detour, or I'm just making this up. You went to Canton, instead you were supposed to go to Akron, so you drove to Canton, then went to Akron. Your mileage is gonna be crazy. Input the correct mileage, then maybe your narratives write down what happened. That way the billing company can reference that and have something to go back on.
Okay.
What other questions do you guys have? Nothing? All right.
I got a question.
Yeah,
I don't know if you went over this. We just got back. Do you want an EHR done for patient lists?
no, that'll be the same as on IMS. You'll go to fire incidents. Then you'll do your CAT import or add an incident, whatever. And then you'll go in to your basics to person and then add person here. And then obviously complete the rest of the, specific information. Obviously, unit reports will be required that you'll have to go in and put, what you did. Your times will be in here, the actions that you did, the personnel on that unit, and then say, medic 2, patient lift, refer to incident narrative, for example.
That's fine. I just asked because at the other job, we just started doing EHRs for patient lists. I didn't know if we were doing that here.
Now, if the per the SOG that we went over, obviously if the patient is assessed or treated, then you would have to do an EHR as like the patient's going to be a patient refusal, for example, you do an EHR. But if it's just a patient lift, the patient has no complaints, you just help them up to a chair or bed, whatever it may be as a quote unquote patient lift, then it's just a fire incident report.
Okay.
Any other questions? Right. Well, we're rounding out about an hour here. The Chief Morton and any acting battalions is going to be, and anybody can really watch if you'd like, if you would like, it's up to you. We're going to go over the quality management tab. So simply you go to the QM here and your information, these are my reviews, but you go to all reviews for the shift, all these will populate. Now, once you click into a document, okay, let's say this is a run that I want to review as the battalion or acting battalion, it'll be marked as not reviewed. But once I click into it, my name is going to be populated in as the reviewer. So if I go back to the dashboard, now it's going to say, okay, I need info needed, and now I'm the reviewer. Now let's say, oh crap, you're changing, it's the next shift and they're going to review it for you. That other battalion or acting battalion cannot review this until you come over to the hamburger stack and hit reassign. And then you can reassign it to that other acting battalion or battalion. And it appears that I did put in the acting battalions in here. So they are in here and they'll have access to this portion also.
If it gets reassigned, Sully, am I able to go back in and look at it as well? Or no?
I
Once
don't
it's reassigned, it just stays with him?
It just stays with him. Is that correct, Adam?
You can click on it. And then you could see like kind of the dashboard of the QM. You go ahead and click on one, Sully, if you don't mind. Yeah, that's fine. So it'll show all of this right here. And then you can select that hamburger button next to Sully's name and reassign it to yourself.
Okay,
If you want to show them how to do that, or you can just back out and it won't change anything.
okay. Got it.
But if you start going further, it'll probably have to reassign it to you.
So pretty simple. Once you click on the document, your name is populated. The summary is literally this is information about this information will come about an EHR. So you have your name, the rating that you can give it. So was this report poor, fair, good, very good, and excellent? That's based off of there's no real stipulations. We haven't came up with a what's good, bad, for, fair, and poor when it comes down to it. The incident information, general information about the incident, and then the clinical portion about, the disposition, what was the complaint, what was the primary impression, and there'll be more information. We'll talk about that here in a minute. So let's say you want to look at the PCR. There's two different ways to look at the PCR. You can click up here, or you can click pop out PCR. And the reports are quite a bit longer than the IMS reports, at least that's what I think. But you'll go down through looking at whatever pertinent information you need to about the report. All attachments should be attached to this. There's the narrative, information about destination, incident information, crew members, what role they had. Insurance information is going to be populated because we're not doing anything with the billing tab. Mileage, any delays, next of kin, signatures throughout here. And a lot of this stuff stays blank because we don't do anything with it. And then a provider signature down there. Pretty simple. Or you can hit PCR here. So pop out PCR will make it big up on the window of your computer, or you can hit PCR and you can zoom in if you so choose to look at it a little bit closer. And then once you look at it, you can come back here and say, oh yeah, this was a good report, good rating on this report. You can look at files that were attached to this record, and then you can actually provide messages to the crew. So if everybody remembers on the front, on your dashboard, so Chief Morton could go in here and say, hey, Block, Bart, and Casper, or just one of them or all of them, hey, good job on this report, just remember to do this next time. Or hey, I'm going to unlock this report, you need to change this, and this. So that's how you can kind of put messages, and that won't notify the members unless they're on the dashboard. Okay, it won't send them email, won't send them a text or anything like that. They literally have to go into the dashboard. So in a roundabout way, you would have to contact them somehow and say, hey, you need to go in the ESO dashboard. There's a couple things I need you to change. But all this is documented also. Anything to add on that, Adam?
Yeah, so just a couple things. You guys, for sake of billing, everything you're going to work in is going to be documentation review. You're not going to work on the clinical review or the billing review part of the module, and we can show you how to change that in a minute. But just make sure whatever you're doing is in documentation review. So I'll hit everything else. I'm sorry.
Oh, I see up there, the documentation review. Okay.
And on the previous screen, you can change what you're searching, because you can see, okay, maybe Solly's doing all the clinical reviews, it would be assigned to him. So you can change that under the type and just flip back to documentation reviews and assign folks as needed or reassign them. But for billing purposes, you need to be in documentation review. And when you hit approve or not approve, that's what's going to send it over to our billing department. And then they're going to do what they need to do. As far as the feedback, you can provide feedback, obviously, and it'll kind of give you selections based on the feedback you want to give. And you can type in some notes with that. Again, this will not send them an email or any kind of notification, but it will, if you do send them a message following the feedback, when they open the message up in their dashboard, it will show this feedback that is being typed on the right-hand side. Notes, to my understanding, stays within the confines of what you see right here, kind of just between BCs, OICs, or acting BCs. Maybe you're tracking somebody keeps missing signatures, like, hey, this is the 4th time they forgot a signature. We got to talk to them, or whatever the note might be. That's kind of internal, but the feedback will go to that individual when you send them a message. And we can, on the back end, we can run reports based off of feedback you give. So it is a nice feature to use. We can look and see how many times we're having QM issues with interventions or protocol. We can't see the notes you give unless we come back to this module you're in right now to see it, but we can look and see what records had feedback of interventions or protocol issues or compliments. So feel free to use that. You don't necessarily have to put notes in there each time either, but the more data you put into this, the more we can pull out later for anything. really.
And then once you're complete, you've done your rating, any feedback or notes that you've done, you'll come up here and hit approved or approved, do not bill. And that's based off of, and I'm not familiar with the standards that you guys, you know, do for that. So,
So if something was omitted that was required that didn't get in, just got missed, then I would click the approve, do not bill, and then send them a message saying, hey, you got to add this or fix that.
No, don't click anything up on the set status too, because as soon as you open it, it's going to switch the status to info needed. So it kind of flags it. So if you can't complete that QM right there, like info is needed, don't select either of those two things. Send them a message, send them a text or email, however you want to do it. Say, hey, we need to fix this. And then once it's fixed, you'd go in there and change the status of it.
Back to the approved or
Approved, do not bill. Yep.
Okay.
Yep.
Very good.
the nice part about messages is it's documented what you say and how they respond and such. Because if I put a message and I send it to myself, for example.
Put me in there too, Sully, if you don't mind.
Okay.
Just because I was having issues sending messages to myself earlier. It wasn't working.
So I shouldn't cuss.
No,
Probably not.
keep it PG.
Do what you want, chief.
Yeah.
Be like, what the hell?
So the recipient list cannot change once the initial message is sent. So once you send this, these recipients can't change. Send it. It almost looks like a text message. So I just sent that to Adam from me and myself actually, and then he can reply back on the dashboard. So let me go back here.
I'm replying right now.
Are you? Okay.
So if you want, Sully, I just replied to you. If you want, I can share my screen to show what it looks like on my end as the viewer.
Yep.
With that message and the feedback, if you'd like.
Yep. 1 second. I think I got to make you the host.